everyone else so that you can have a special admission process to the webinar, basically.
Okay, hi Linda and hi Marianne.
Okay. But they are muted. I think Marianne has a problem with the audio and Linda is on mute mode. So guys, I think it's 4:01, right?
Yeah.
Okay.
No, yeah, that's it. Hi, Linda.
Hi, Linda.
Okay. Let's admit everybody.
So we have 30 people in the waiting room. I'll admit people and we'll start in 1 minute. Okay?
Inshallah. Okay.
Here we go. Khattab, I'd ask you to keep an eye on the waiting room if you don't mind.
Okay.
People keep joining. And we'll just start our webinar. Good afternoon, everyone, and welcome to our, we continue with our series of AO Spine GCC webinars. Special welcome to all the people joining us from South America, from Asia Pacific, and from Europe. I know that you guys have a lot of time difference between the different places around the world. So thank you. It means a lot to us. We have registered attendees from 42 countries around the world. That's a large number of countries with different backgrounds and different spine schools. So it's really a pleasure having all of you tonight, and hopefully we can have a successful webinar with your input as well. Today we'll be talking about a very controversial topic. We are not going to be showing you any fancy x-rays or deformity cases or anything like that yet. We'll be showing you something that we deal with in our daily practice as spine surgeons. And whether you like it or not, it's part of your practice. Pretty sure all of you have been through this before. This is going to be an interactive session. We're going to ask for your opinion as attendees and for the opinion of the panel as well. And then we'll see what the literature is supporting regarding the different ways of treatment of dural tears. Now, joining me for the webinar today is Dr. Omar El-Nouri. Omar El-Nouri is a consultant orthopedist and spine surgeon at Hamad Medical Corporation in Doha, Qatar. Omar had his spine surgery training in Boston Medical Center in Boston, Massachusetts. Welcome, Omar. Great to have you on board.
Thank you, Sameh.
Joining me as well today as a co-moderator, Dr. Mohammed Khattab. Mohammed Khattab is an associate professor at Ain Shams University in Egypt. You probably recognize him from all the wonderful activities that he has been involved in the online space over the past few weeks with the lockdown. Great to have you on board, Khattab.
Thank you, Sameh. Thank you very much, dear friends. It is really an honor to be with you, cooperating in such amazing activities. You know, today is our 27th international webinar during these, I call it COVID-19 episodes.
Exactly, it is. And how many total number of attendees you had in those webinars?
More than 3,000. Wow, more than 3,000 from all over the world.
That's pretty impressive. I think that's the power of webinars, and that's the power of the internet space. And we're probably going to continue like that for a while till we're over with the current situation. So without any further ado, let's start our webinar. We'll be starting with a quick case here. So this is a 79-year-old gentleman who presented to our clinic almost a year ago with low back pain with bilateral radiculopathy. It's very important to mention that he had urinary retention secondary to previous cervical myelopathy that he was operated for 17 years ago with C2 to T2 with C5, C6 corpectomy with C2 to T2 posterior cervical fusion. Very important. Since then, he has been self-catheterized, and he also had L3 to L5 posterior decompression 20 years ago. On examination, he had a muscle strength of 4/5 with bilateral knee flexion, ankle dorsiflexion, and EHL. Now, as you can see here, his x-rays, he has degenerative scoliosis of the lumbar spine with multiple degenerative levels of disc disease levels with spondylotic changes, anterior osteophytes, and narrowing of the foramina. Here's his MRI. You can see he has L2 to L5 bilateral foraminal stenosis. Now, most of you would probably argue that this guy needs a fusion surgery, but we had a lengthy discussion with anesthesia, with cardiology, with internal medicine, and basically the guy was not fit to go through a long fusion surgery. So, and he was also allergic to steroids, so epidural steroid injection was not an option as well in that case. So after a very long discussion with the patient, we decided to go with L2 to L5 posterior decompression, giving him the heads up that he might end up with some sort of instability and that he might need a fusion in the future. Unfortunately, during the surgery, with all the scars from the previous surgeries that he had, we had an incidental duodeotomy. We sutured that with a continuous 4-on urolone. We didn't use any patches, and a hemovac drain was applied in the subcutaneous space. So basically, it was closed tightly in layers, and the drain was on top of the fascia. Here is what we did. Here's the dural tear that we had. So basically, we assured the hemostasis using patties or cottonoids, and then we stopped the CSF leak with a cottonoid as well. And then we widened our laminectomy so that we can see the edge of the dura. That's very important. And then we started anchoring our suture at one of the ends of the tear. We used a continuous running technique. In this case, final knot, Valsalva to 40, no CSF leak. We assured hemostasis, and then closure in layers, tight closure in layers. Post-op course, 24 hours bed flat as per protocol in our institution. Then on post-op day 2, we tried head of bed elevation. Unfortunately, that was very unsuccessful because of severe positional headaches. So I'm gonna stop here and I'll ask you guys, I'm gonna ask the attendees, what are you guys gonna do next? I need your input. You'll have a poll in front of you and you have 10 seconds to vote for the poll. So wait and see, do an MRI, or take him back to the OR. All right, 5 more seconds. People are still voting. All right, pretty interesting. Let me share the results with you here. So wait and see. Almost the majority of you, 2/3 of you have chosen to wait and see, while almost 30% of you have chosen to do an MRI. All right, we'll get to the resolution of this case by the end of the presentation. All right, so the first thing that we're going to talk about today is the incidence of dural tears. And for that, I would like to ask you once again, what do you think the incidence of dural tears in primary spine surgery is? Is it 1, 3, 5, 7, or 10%? 30 seconds to vote. All right, sharing the results.
So as I can see here, the majority of you guys choose between 3 to 5, and that's actually what we are telling. I'm telling to my patient in surgery. What about you, Khattab? What's the percentage? Do you think? It's
I think it is 7%. You know, it is completely different. If you check the literature, you will find different range. But I think 7% is quite reasonable number.
Okay, let's see what the literature will say. So there's a one study which was published in Spine in 2000 by Camisa, and he studied around 2,000 patients, and the overall incidence of incidental duotomy was about 3%, and it was higher in revision surgery. There is another paper which was also published in Spine in 2006 by Khan, and he studied more than 3,000 cases. And the incidence was between 3 to 9% in primary procedure, and it was up to 16% in the revision surgery, which is, I think, is pretty understanding and pretty logical there will be more scar tissue and more adhesion, and sometimes you cannot differentiate between the scar and the dura, and that when incidental durotomy will happen. So now we know the incidence of the dural tear in general. Is there a difference between open tubular endoscopic discectomies, or there is no difference? Can you share your opinion, please, and vote for this one?
Right. 10 more seconds. Okay, let me share the results with you here. So I can see that the majority of you, 40% of you, have chosen, we're in favor of no difference between all of them. And then it was the least for tubular discectomy, which is pretty interesting. And then it was almost equal results for open discectomy and endoscopic discectomy. What do you think, Khattab?
For me personally, in my hands, that I faced dural tear more with tubular discectomy or microscopic discectomy in minimally invasive surgery, working through a little bit smaller corridors. So in my hand, it is more common with microscopic discectomy or minimally invasive discectomy, unlike open or even with endoscope.
All right. So I agree with you. I grew up as a spine surgeon under the understanding that I probably got more dural tears using tubular discectomies, probably because of the narrow space. You have higher chances of injuring the dura. But let's see what the literature says. So in this literature review that was done by Mike Felling in the University of Toronto, and basically it was a 10-year systematic review of the literature, they included in that 19 studies, and they had a total of more than 1,300 durotomies. They compared the incidence of dural tears in open versus MIS discectomies. And what's interesting is that they found that there is no difference. All right, what about endoscopic discectomies? Do you think it has higher incidence of dural tear? Let's figure out. The German group in World Neurosurgery in 2018, again, it was a review of literature. They involved 12 studies. And once again, there was no difference between endoscopic and open surgery when it comes to the incidence of dural tears. So now, since we know the incidence of dural tears and that there is no difference with whatever approach you use, what are the risk factors or predisposing factors for dural tears?
So as we know, there's multiple predisposing factor for dural tear. But let's see what's published in GNS Spine in 2015. They studied multiple predisposing factors for incidental durotomy, but the one which was statistically significant was the older age and revision surgery. There is another study which was published by in Turkey Neurosurgery in 2016 by the Turkish group, and they studied multiple factors, and they found more than 1,000 cases, and they found that it's more common in recurrent disc surgery, female 6, epidural anesthesia, open discectomy, non-dominant hand usage of the surgeon, and it's more in the upper level of affected lumbar disc disease, like it's higher at the level of L1-2 more than the lower level, which I think maybe because of the tighter, smaller lamina and bigger facet at that area. Now we know the incidence of and predisposing factor. So what's the management? How we'll deal with this situation?
So here's how I'd like to look at this. I think of it when I manage dural tears as three ways or three mechanisms of dealing with dural tears. The first mechanism, in my opinion, is pretty straightforward. You need to stop that CSF leak, whether you do that by suturing, by sealant, by patches, or whatever way, or a combination of both or the three of them, or whatever way you do to stop that CSF leak. The second mechanism, which is very important, is you have to reduce that subarachnoid fluid pressure. Now, whether you do this pharmacologically using some acetazolamide, carbonic anhydrase inhibitors, or you do that using subarachnoid drains. The third mechanism, which is underestimated in the literature actually, is increasing your epidural space pressure. And that happens with your tight closure. So basically, when you do that tight closure in layers through the muscles, fascia, subcutaneous tissue, and even tight closure of your skin, that ensures that you have a higher pressure that will stop that flow coming through your durotomy. Now, let's jump to another point here. Since we're talking about suturing, what suturing technique do you guys prefer when you go for your durotomies? Do you prefer simple interrupted or running sutures, running technique? And once again, we have a poll for you guys. And let's see what you think is better. All right, let's share the results. And I can see that 2/3 of you prefer to go with the running technique. Which one do you prefer, Khattab, by the way?
For me, actually, it depends and rely on the size of the tear. If it is a small tear, I will do interrupted sutures for sure. If it is a huge, big one, I can do running stitches, but I will augment it with interrupted as well. Simply because running continuous sutures, if you lost one of the nuts at the end, you may lose everything. So originally, I prefer the interrupted, but in bigger one, I can use continuous augmented by interrupted.
All right, so I agree with you. I use both techniques. Depends on the size of the dural tears, depends on how accessible my dural tear is. But let's see what the literature says. So most of the people here are in favor of the running technique, but is it true that the running technique is superior to the simple interrupted technique? Let's see. Now, that's a very controversial topic in the literature. So you'll find a lot of paper from the ancient times till nowadays. This is a paper in 1988 in spine, another paper in 1994, a third paper in clinical spine surgery in 2017 by Gabriel. And basically, if you read all of those papers, you realize that their successful outcome was equal in both techniques. So basically, there was no difference. Then another paper that was published by the group at the University of Wisconsin in 2015 in the Spine Journal. Basically, if you check that graph on the left side, you'll find that as your hydrostatic pressure increases, your flow rate will decrease in favor of the interrupted technique versus the continuous. But that wasn't neither statistically nor clinically significant. So basically, I would say use whatever you're comfortable with because the literature is supporting you both ways. Now, since we talked about suturing, which suture material do you guys prefer? Is it Prolene, Surgilone, or Gore-Tex? And once again, would ask for your votes. And here is the poll. Right. Thank you for voting, sharing your results.
So I can see that the majority of you, more than 80%, they choose Prolene, which actually what I'm using it in my clinical practice. What about you, Khattab?
For me, actually, I prefer silk because, you know, silk is cheaper and we are in a price-sensitive market. Plus, silk actually invites the fibroblast aggregation, which can help sealing of your tear. So I will add for this poll silk and I will choose it. If it is not available, I will choose Prolene. Surgilone and Gore-Tex, I think it is very expensive one.
Okay, thank you. Let's see what the literature will say. So here's one study which was studying the 5-O Surgilone with the 6-O Prolene. And as you can see here on the right graph, as the hydrostatic pressure increase, the mean flow rate will decrease when we are using 6-O Prolene, which was statistically significant, especially between the pressure between 40 and 90. So now we know about Prolene and Surgilone. What about the Gore-Tex? There is another study which was published by Gabriel, and he studied, this was a cadaveric study. He divided the patient into three groups. running, locked, continuous, and interrupted. And he used two types of suture, Neurolon and Gore-Tex. And interestingly, Gore-Tex was superior to Neurolon in all three groups. And it has lower operation rate, reoperation rate.
I think, Omar, the advantage of Gore-Tex over the other two. So the advantage of Surgilome basically is that it's braided. So whenever you're using a running technique, you don't really need to keep that tension on your stitch. You're pretty sure that by the end of suturing, you're not going to have a loose stitch since it's braided. And I think the advantage of Gore-Tex over the Prolene and the Surgilome is that you have a larger diameter of a thread than the diameter of the needle. We always worry when we go with that stitch in the Dural that we created a hole already using the needle. So if you have a bigger diameter, which is the case in the Gore-Tex, you're pretty sure that you're going to seal that diameter with a larger thread following your needle. The other thing that you can use as well, if you're using 6/0 Prolene over a 7/0 needle, that's not available in all of the hospitals, and it's much more expensive than the regular Prolene. But if you have that as well, then you'll have that advantage that the Gore-Tex has over the other suture material, which is a bigger diameter of a thread over the diameter of the needle.
Exactly, Sameh. Yet, but we have to know that there is a failure rate when we are using a suturing technique as it's published in 2017 by Zhou, and it was between 5 to 9%, which is pretty high. So now we know about the suture technique. What sealant material you prefer to use? Is it T-Seal, Duraseal, or Dermabond? And can you please vote for that?
Five more seconds. All right, great. Thank you for voting. Now I'm casting your votes. All right, so I can see that we almost have 50-50 between T-Seal or fibrin thrombin versus Duraseal. And no one is basically using Dermabond. So we had only one vote for Dermabond. Khattab, which one you use?
All of the above. You know, when you have a complication, you need every weapon in your operating theater to manage your complication. So if I have, for example, dural tear, I will suture it. I will apply fibrin glue. I use Tachosil as well before the fibrin glue. I will apply fat graft. I will apply muscle graft. I will do everything. So actually, if I have a complication, I try to do everything. So
right.
it is a difficult question, Sameh, to choose. But if you want me to choose one, it depends on what you have in the operating theater.
I totally agree with you. It definitely depends on what you have in your institution. It depends as well on the cost in your country of those
yes.
products. Products are not cheap, and the market varies widely. The price varies widely from one place to another. But I can tell you, let's see what the literature says. So I can tell you that honestly, 2 years ago, or almost a year and a half ago, I didn't know that Dermabond can be used as a sealant in dural tear. And it's very important to state here that using Dermabond for dural tears is an off-label use for Dermabond. Yet it's pretty widely mentioned in the literature, and I've used it before. So let's see the difference between the three sealant materials. Now, the good thing with Dermabond is that it's ready to use, right? You have it ready in that vial. You just need to crush that vial and run it the same way you run it over the skin. The only problem with Dermabond is that in order for it to work, it takes like 3 minutes, and you have to keep that field super dry for Dermabond to get that sticky, hard material, and it can seal your tear. And let's face it, to be honest with you, that's not the case that when we have those tears, right? Usually it's a little bit messy. You have bleeding over here and over there, and you have CSF running. So it's not that dry to keep that field super dry for your Dermabond to work. What about Evaseal? basically it's fibrin and thrombin, and a lot of people are using that already for hemostasis, not just for dural tears. Evaseal works really fast. Now, the only problem with Evaseal is that you have to keep it in that centrifugation machine for like 10 to 15 minutes. And let's face it, I mean, with some surgeons, the discectomy can probably take 15 to 20 minutes, right? So waiting for that Evaseal for like 15 minutes to be ready, that's pretty crazy as well. Uraseal is probably the much more accepted sealant material and much more widely used in the market. Now, the good thing of Duraseal, it takes 2 minutes to mix those vials, the blue and the transparent vial, and it works right away immediately when you use it. Right, now, since we know how each of those work, which one is superior to the other? Let's figure that out. Now, if you look at that graph to the right, you'll find out that Duraseal is definitely superior to TCL and Evaseal, or thrombin and fibrin, if we're not talking with the market name of the product. But what's more interesting is that Dermabond is superior to both of us, right? Once again, I'm not saying that you guys should use Dermabond. Use it if you have tried before and you're happy with, you have literature that supports Dermabond. But again, this is going to be an off-label use. All right. There's a very important point here that whenever you guys use Duraseal, which is again the most commonly used sealant, bear in mind a very important thing. In this study that was published by Kim and Wright in 2011 in Spine, whenever you put that Duraseal stuff on your cord or on your dura, bear in mind that it increases in size by 50%. And that doesn't happen immediately. That happens over a couple of days after you introduce that product in there. And that's pretty freaky when you put that on the cord, on a cord level, right? Because they reported 2 cases of cervical cord compression using Duraseal. So this is pretty scary. So just bear that in mind whenever you use those products. Now, moving forward, since we're done with the sealant, what about grafts? Now, we have a lot of grafts in the market, but we have autogenous grafts as muscle grafts, fascia grafts, fat grafts. And then we have synthetic grafts with lots and lots of companies in the market. Probably the most commonly used synthetic graft is the DuraGen graft. Once again, I'd like to ask for to cast your votes in the poll in front of you to see which one you prefer as a graft. Right, 5 more seconds. Right. Let me cast the result with you.
So I can see that here it's evenly distributed, and actually it is depend on the situation or the hospital which you are working on. What about you, Khattab? Which one you will use?
For me, the gold standard is a fat graft. You know the capability of the fat cells to transform to other forms, so it is very helpful. And the second option is actually muscle graft, and I will use it as a supplementary to the fat graft. As I told you before, I use everything that I have. Regarding the synthetic graft, it is a very expensive, but maybe I will add something more, which is fascia lata autograft from the patient himself in big, huge tears. You can use fascia lata graft.
Okay, let's see what the literature will say. So here's one paper which was published by Joseph in Spine 2009. And he studied about 144 patients with incidental durotomy. 6.3% of the dural defect were repaired with crushed muscle and fascia. And all patients were successfully repaired without need of other surgery. And there is another study which was published by Song, and it was a rat study, rat model dural tear, and he studied if there is any inflammation happening in the cord, and he found that there's a series of inflammatory reaction in spinal cord after dural tear, and which will impair the sensory conduction function. So he stated at the end of his study that repair with the fascia could attenuate neuroinflammation and help to maintain normal sensory conduction function. What about the fat graft? So here's another study, which was by Chapok, the effect of fat graft. And there was success rate with using fat graft, what, 87%. And it was an excellent alternative to other type of graft, as it could revascularize and prevent scar formation and do not adhere to a neural element. Now we know about the graft. Let's see what's other modality that we have.
Now, as we said before, the other modality is reducing your CSF pressure. And as I mentioned earlier, you can do that either pharmacologically or using a subarachnoid drain. Now, let's see let's talk about acetazolamide. And I have seen my colleagues in neurosurgery use it commonly. I honestly don't use it whenever I have a dural tear, probably something that I should consider in the future. But let's see this study. So basically, they had two groups of 28 patients each. The first group, they gave acetazolamide for 48 hours with a dose of 25 milligrams per kilogram per day. And for the second group, they didn't, and they had 100% success rate with the first group versus the second group that continued to have a CSF leak for 14 days. So the literature is pretty supportive of acetazolamide. What about the other technique, which is subarachnoid drains? Now, subarachnoid drains is probably one of the things that has been mentioned in the literature since the very old era, right? If you look over here, you'll see this paper in the JBJS in 1989 and another paper in neurosurgery in 2011 by Farhat. And basically both, if you read those two papers in details, you'll find that they mention a success rate of up to 94%. 94% is pretty high, but there is the other ugly truth, or the ugly side of the story, that we have a complication rate of up to 45%, which is crazy, right? Most of those complications were due to overdrain, pneumocephalocele, or meningitis. And then 17% of those patients complain of nerve root irritation. Another paper, 19 patients where subarachnoid drains were placed post-operatively. Now, it's very important to mention that when you drain those guys, don't drain them more than 200 to 300 ml per day. Otherwise, those patients will have severe headaches and they will hate you. So always keep it reasonable to 200 to 300 ml per day. Now, 15 patients had the leak resolved. 2 patients had bacterial meningitis, which is a pretty catastrophic complication. But when you read the paper in detail, you realize that they didn't use any prophylactic antibiotics. So here is what I would say. If I am to use subarachnoid drains, I'll definitely keep all my patients on prophylactic antibiotics. No one wants to risk a simple discectomy case that ended up with a dural tear and ending up with meningitis. That's a catastrophic outcome, in my opinion. Now, let's move on to mobilization. So after you repair your durotomy, what do you usually do? Do you keep your patient flat in bed for overnight, for 24 hours, 72 hours, 4 days, or it depends? And let's see what you guys think about that as well. Five more seconds. Sharing your results.
So I can see that here there is no consensus what protocol you should use. What about you, Khattab? Which one
you know, it really depends. If you are really happy, and I think all of us must go outside the surgery happy with our repair, properly watertight sutures, and you put fat graft, everything. So I will allow only overnight. Overnight is for me enough. It is okay for me.
Okay, what about you, Sameh?
Well, whenever I have a dural tear, I always place that order of for 24 hours, bed flat, right? But then when I go to see the patient in the morning, it's literally, I usually cancel that order, right? I start mobilizing them right away. I normally patient, honestly. So I keep elevating the bed a little bit for like 15 minutes or something. If they are tolerating it, I usually start ambulating them right away. It's very important though to mention something here, Omar, before you proceed with your presentation. Whenever you have a dural tear and you go the next morning and see that patient, stop asking him if he has headaches, right? Now, most of the patients have headaches after surgery. Most of the patients have headaches from the effect of anesthesia and everything. It's only positional headaches that count, right? So if they say something about positional headaches that, I'm not saying not to disclose the dural tear, definitely disclose the dural tear to your patient, but stop asking him, do you have headaches? Do you have headaches? Well, the majority of patients have headaches. Believe it or what, patients in North America who are hammered by narcotics, most of the time before they get to the OR, they have probably been on narcotics for 3 or something, or 3 months or so. And when they're coming out of the OR, they will definitely have headaches on the next morning of surgery. So just to keep that in mind.
There is a lot of controversies, and actually there is no real study that's showing there's what's the proper protocol. But here's the ongoing clinical trial, which was done by Zurich group, and it's still ongoing. They had a protocol for the dural tear, incidental dural tear. So they will keep the patient for 24 hours, bed rest. Then they will start head elevation 30 degrees for 8 hours. Then they will start ambulation. If there is no headaches, that's the success for them. And the preliminary result shows very good result, which is rewarding, and the patient did not went to reoperation again because of that. So what about like the predisposing factors that affecting poor healing of dura? Most important is the infection, large dural defect, and loss poor soft tissue coverage, nutritional deficit, steroid agent, and elevated CSF pressure. And here I have to stress about steroid agent. So please don't use steroid when there is a dural tear. Don't use the holy water when there is a dural tear, because it will simulate the infection and it will prevent the healing of the dura.
Exactly, Omar. And now, last but not least, before we jump up to the case resolution, we came across this protocol that was published by the St. Joseph Hospital group in Paris. And it's probably going to ask our last question here, which is whether to use a drain or not whenever you have a dural tear. So take a look at the protocol. It's pretty easy, actually. So if you have a dural tear, always cover your patient with antibiotics for 48 hours, right? Now, if your dural tear is repairable and you're able to get a tight suturing of your tear, then you can use a drain, but never to put it on suction, all right? Anything other than that, whether you weren't able to get a tight closure or it was irreparable in the first place, then don't ever use a drain, all right? Because you will be sucking that CSF straight out of the dura to the drain outside. Right? So I would recommend not to use a drain as per the literature. And then the advice for 48 hours bed rest, I don't really agree with that. I would say whatever you guys are comfortable with. If you think your patient can tolerate ambulation after 24 hours or after an overnight bed stay, then that's something you can do based on your experience in your practice. But I definitely agree with them when it comes to the drain. What about you, Omar and Khattab? Do you guys use drains when you have dural tears?
Me, yes. I try to do subfacial drain to decrease the stresses over the wound, and I remove it. I'm speaking about the suction drain, and I remove it after 24 hours in order to decrease the stresses over the wound. But regarding the subarachnoid space drain, I used it once, only once. It was, dural tear cannot close by any mean all over a period of 1 week, and the patient start to complain from positional headache and photophobia. So I used this subarachnoid drain.
Okay, for me, I'm not using a drain at all, actually, unless like there's multiple revision surgery and it's complicated with dural tear, maybe I'll use drain. But for me, I'm not a fan of drain, and I think it is some kind of source of infection. And that's what I trained in, and that's what I'm doing actually in my practice. So I'm not using a drain at all.
All right. I don't use a drain as well, to be honest with you guys. If I'm using a drain, I'm worried about hemostasis or anything like that, and I have a dural tear, I probably use a drain in the subcutaneous space. But I wouldn't use a subfacial drain when I have a dural tear, especially if I'm not happy 100% with my closure of the dura. Especially when you have one of those dural tears that are really on the side or the front or anything like that, I wouldn't use a drain with those. But again, it's something that's not really solid in the literature. So let's jump us to our case resolution here. So remember our guy, he had positional headaches on day 2 post-op. So we decided to wait for one more day. Unfortunately, on day 3, his dressing was super soaked with CSF. Actually, not just his dressing, the whole bed was soaked with CSF. So we talked to the patient when we decided to take him back to the OR, and then we found that there is a CSF leak from one of the ends of our closure. And it's always one of the ends of your closure. When you take those patients back to the OR, you will not find the leak coming from the center of your closure. It's usually one of the ends, right? Whether you ripped that end with your suture or it's something that you didn't close really well, I don't really know. So we augmented that with an extra stitch, and then we decided not to risk it. We applied a Duragen on top. Now it's very important to mention there are 2 types of Duragen in the market. There is one that has a smooth surface on both sides, and there's another one that has a smooth surface on a side and a rough surface on the other side, like the one we used over here. Remember, when you use this one, always have the smooth surface facing the dura, otherwise your Duragen is useless and it will never work. Now, the manufacturer would tell you that Duragen doesn't need to be sutured to the dura, and true, it doesn't need to be sutured to the dura. But I can tell you that a couple of times we opened patients back for some complication or persistent CSF leak or something like that, and we found that Duragen to be all over the place, all right? It wasn't really where exactly we put it there. So if you'd like, you can anchor your patch with sutures at every single corner just to make sure it stays in place. That's something based on whether you like to do it or not in your practice. Then always remember that bleeding is your friend here, all right? You really want to have that blood clot on top, and your Duragen works much better if you have bleeding on top. So initiate some bleeding if you don't have already some bleeding in your field by just cutting into the muscle or cutting into the fascia, right? Finally, we assure the hemostasis using whatever agent you use, whether it's flow seal, Surgiflow, or even cauterization if those are expensive in your countries. And then the patient was closed tightly in layers and he had no complications. We followed him for a year after and he didn't have any iatrogenic instability. He was lucky, I guess. And his radicular pain was much better and he was very thankful for the outcome. So one last thing before we go, based on this webinar, if you guys have all the material available and all of them are affordable, which one of those would you guys use? Suturing alone, sealant alone, patch only, suturing plus sealant, suturing plus patch plus sealant? All right, you have 5 more seconds. All right, thank you for voting. And of course, no wonder, most of the people I've used every single tool in your box to fix whatever complication you have, as you said earlier, Khattab.
Yeah, totally I agree with you, Sameh. Totally I agree with the audience here. I will use every tool that I have it, if I have the feasibility to use it. Because I don't want to take the patient again for reoperation, and it will be a disaster for the patient, high risk of infection. So use whatever you have in your toolbox, and I mean, I know sometimes it's difficult and it's more expensive for the patient if they are paying for it. But if you have it and you have the luxury of using it, use it. Don't hesitate.
Yes. Great, but you know, I'd like to highlight something, dear friends. It is really amazing presentation. I enjoyed it very much. But you know, there is a spontaneous resolution of any dural tear. I'd like to tell you that every dural tear will heal at one time, even if you didn't notice it, if you didn't face it intraoperatively, if you face it later, it takes only a time. You know, the soft tissue healing cascade is about 3 months. I can remember one of my patients that I did microscopic L5S1 straightforward microscopic discectomy case, and he was an engineer, high tech, high professional, intelligent, everything, you know, and the post-operative period was uneventful, and he presented to me after 6 weeks by swelling around his back. And it was a pseudomeningeal, CSF. Of course, you know, regarding the diagnosis of the CSF, you may need to do MRI, or it can help you to identify the pathology, and you can even in expert colleagues, they can identify where is the rent itself. But you know, the aspiration and assessment of beta-2 transferrin is pathognomonic for CSF. And I did for him, and it was, as I told you, pseudomeningeal. And I reassured him, and I told him, any dural tear will heal by itself. If you want me to open and resuture and do everything, I can, but wait for 3 months. He chose to wait, especially it is only this swelling. And after 3 months, he came to visit me without any swelling. So what about the presentation of dural tear in your practice, Sameh and Omar?
You mean the late presentation of dural tears?
Yes, you may have it intraoperatively or immediately post-operative in the drain or leak from the wound, or late presentation. You know, there are 3 times you can face the dural CSF leak presentation. How is it differ in management from early to late?
Sure. So I would tell you something. Regarding the late presentation dural tear, I went through that through the literature about that almost a year ago, and to be honest with you, I'm not really sure if it is a late presentation or if it was a dural tear that was missed in the primary surgery. Okay, because there is a very famous paper that was published almost 7 years ago by the group in the Rothman Institute, and it mentioned that the incidence of missed unnoticed dural tears during primary surgery is up to 6%, which is pretty high, actually. Now you can argue whether you got a dural tear from a spike of bone that you left, and when the patient started ambulation, he hit his dura against that spike, and that's when you had a dural tear, where all of those are theories, right? Because we don't really know what happened.
Okay.
It might have been a dural tear that you had in the primary surgery and you missed in the first place. But I can tell you that I still remember my first cases and attending. It was a 2-level TLIF surgery, revision 2-level TLIF surgery. And I remember it was a 3-4-4-5. And the 3-4 level was, the disc height was almost gone, totally gone. And, you know, was my first case back then. And I wanted to get a cage in the 3-4 level. And I managed to get a cage in the 3-4 level. But I didn't get any dural tears intraoperatively. Then a few days later, I realized that the patient's dressing upon discharge is soaked with CSF, right? So it was probably an indented dura secondary to the collapsed disc level at 3-4. And when I jacked that up with the cage, that's when I had a dural tear, particularly with the scars from the previous decompression surgery. That patient taught me a lot of things. So I took him back to the OR, honestly, and I couldn't find the dural tear because obviously it was something in the front. I kept doing Valsalva. I couldn't find any CSF leak. I closed him, kept doing regular dressings for him, and his dural tears stopped spontaneously after 15 days. So I would say I'm now more lenient towards being patient. Like, don't push your patient to the OR immediately. be patient a little bit, wait for a little bit. That's provided that the patient and the family, you, the patient and the family are on agreement that you will continue to have some CSF leak over the coming few days.
Okay, thank you, Sameh, for sharing your experience. We have some engagement from our attendees. We had 80 attendees. There is one of our colleagues asking about the management of post-leak headache. I think I encourage my patient to drink plenty fluids, drink tea, coffee, you know, these caffeine containing drinks. And you know, I use Sidamex, which is a carbonic anhydrase inhibitors, plus Panadol. Are you using other or more modalities or technique, Omar?
Actually, we are using the same. We encourage the patient to drink more fluid. The carbonic anhydrase, actually, we are keeping it for refractory cases. We are not keeping it for the primary. I mean, we'll give the patient time for conservative management. And then if he didn't respond, maybe then we'll think about using the carbonic anhydrase acetazolamide. But actually, we'll give paracetamol, fluid, and wait. Wait for how long? It depends, actually. It depends about the whole situation. It depends the patient, if he's bearing for you, and how much amount of discharge that he's discharging. So it's depends on multiple factors. It's not actually, there's like strict, I will wait for 1 day or 2 days, and then if it does not resolve, I will take him to the OR. Case by case, it's depending case by case.
Completely agree with you, Omar. You know that CSF produced by around 500 milli per day, 500 milli per day. And if the patient developed photophobia, positional headache severe, and photophobia, and you know, you may be afraid from conization or intracranial hemorrhage. That is when the symptoms become severe. At this time, I think you may to need intervention.
Yeah, and I need to add the point that just the Trendelenburg position also is very important. It's very helpful for the patient, actually. When you are doing, it will decrease the pressure over that area, and it will decrease the headache, the bout of headache. So even if you decided to wait and see, put him in the Trendelenburg position, encourage a fluid, and wait for 24 hours. If it's resolving or decreasing the discharge, then that's it.
Very important that you mentioned the Trendelenburg position. It's very important to stress on the fact that lumbar dural tears are different from cervical dural tears. Basically, with lumbar dural tears, you want to keep your patient flat or in Trendelenburg position because you need to decrease the pressure, the hydrostatic pressure at the site of the dural tear in the lumbar by keeping the patient flat. But with the cervical, you decrease the pressure at your durotomy site by keeping the head of bed elevated. That's how we decrease.
Trendelenburg position.
Reverse Trendelenburg. There is a a question here regarding when would you do MRI. MRI immediately post-operatively wouldn't tell you that you have a dural tear, right? Because you'll find a high signal over there that you don't know whether it's CSF, you don't know if it's a hematoma. In my opinion, the study of choice, which is not available in most of the centers, is a cisternogram. Now, cisternogram would tell you truly if you have a dural tear, but that means that you have to inject a dye in your dura, and you'll have to follow that dye to figure out that you have a dural tear and where the site of dural tear is. I think it's pretty invasive. We personally used it once in a laminoplasty patient who developed a dural tear post-operatively, but we don't commonly use it. Omar and Khattab, any input on the MRI post-operatively?
I'm completely agree with you. Early, it may be a little bit difficult due to the surrounding tissue edema and hematoma, but late high signal, or I want to say the Tesla and the expert radiologist can help you a lot.
Totally agree with you. I'm doing actually the MRI only for late presentation dural tear. Like I had one patient, she was a medical student, very thin. I did for her a simple lumbar discectomy, and she was fine, doing fine for 2.5 weeks. And we removed the suture actually after 10 days from the surgery. And then she called me that she had a headache, which is complicated with blurred vision. That stayed for 2 days, and then this resolved by itself. And then she came to me the clinic with a discharge. At that point, I did her MRI for her, and I found there is a collection at that area. But because of the continuous discharge, I widened the laminectomy side. And unfortunately, I didn't find anything. I put my sealant, Dural seal, and closed it, and luckily she's doing fine.
Right. I have one of the attendees here who has his hand raised. I don't have your name, unfortunately. It says iPhone over there. So can you please introduce yourself and ask your question?
Hello, do you hear me?
Yeah,
Yes.
Can hear you.
Hello, Assalamu alaikum. This is Siraj Bilkhair. I'm from Qatar, neurosurgeon. So I just want to add a comment about what you mentioned about having a drain. Actually, during my residency in Halifax, Canada, then I did the fellowship in Toronto. We always use, if there's a leakage from the wound, we come back and do the surgery, like second surgery. But actually, it is until since I moved to Michigan, one of my colleagues, I noticed in the OR, like when he has a CSF leak, he closed it. He tried to close the dura, then he put the sealants and everything, but he puts a drain, and then he closed the fascia tight. The reason behind that, when I looked at it, and I also checked that his post-operative cases, we actually wrote an article about it. The reason of putting a drain, then you close the fascia tight and also the skin watertight as well, is during the 3 to 5 days when you have the drain, you are preventing the CSF from leaking through the fascia, through the skin, which is the most common cause for you to go back to the surgery. And reviewing the data from the hospitals called Genesis Hospital in Michigan, they didn't do any revision for about 3 years because of this technique. When they have an active CSF leak, they try to close. If they can't, they put the drain in, they close the fascia watertight, they put the skin, they close the skin watertight, they keep the drain for 3 to 5 days, and then they remove it. By that time, the fascia and the skin is healed, sealant, and the CSF will not pour out. So I just thought to share with you this experience, which I'm using currently in my practice in case if we have a CSF leak that we can't really close or reach the border of it. Then we put the drain, we close the fascia watertight, we close the skin watertight, then we keep the drain for 3 or 4 days, remove it, and we don't have any problem with the active CSF leak through the wound. I just thought to share this experience with you.
So before you go, so you basically would keep every single patient that you have a dural tear with, you'd keep him in the hospital for 4 to 5 days with the drain.
Yes.
Okay.
Then you remove it. And by that time, the fascia, the wound will heal. And that will make sure that it keeps the epidural pressure with the CSF collection from pouring out through the fascia or the wound. Because as I mentioned, usually when you go back to the surgery, it's because there is an active leak through the wound. This is what will make you go back, not actually the swelling and the wound or the symptoms. And by doing that, you are reassuring you have everything sealed and closed before you remove the drain and the CSF start pushing through your wound. And when you put that drain, it has to be under the fascia. So pass it through under the fascia, under the muscle, and through a separate, away a little bit from the wound. And that will make sure that after you remove the drain, everything will be closed and tight.
Right. Thank you. As Omar mentioned, and I mentioned during the presentation, it's a very controversial topic, actually. And I definitely see your point. It's definitely a valid point. And it's really controversial. So whether you use a drain or not, the literature is supporting you in both ways. But definitely your point of preventing that CSF from coming across the wound, which is actually really the most common cause of taking your patient back to the OR. That's totally true. I totally agree with you when it comes to that. I personally don't use a drain, but I definitely see your point. I have another hand raised here by Dr. Khaled Faraj. Please unmute yourself and ask your question.
Hi guys. First of all, I would like to thank you so much regarding to this comprehensive review. Thanks a lot, Sameh, Umar, and Dr. Khattab. So just, for in my practice, more than 20 years, never ever I used a drain, except, for last, actually more recently for a couple of cases when I had a difficult to control, the dural chair, which was locating actually centrally in front. And, during my experience, I haven't faced that before. So my question to you, and also I noticed that, from many of the attendees from the audience, they're asking how to manage guys with the front, with the, ventral or a front tear when it is expensive. So I want to just to know from Dr. Khattab and from you guys your experience about this one here. Second thing to mention, Dr. Khattab, yes, it depends upon the situation. For every case, you can use as much as you can to try to control your leak, as well as to avoid any come back again, to take him back again for surgery. But did you, Dr. Khattab, did you face it? Because I did that before actually, but sometimes you will make some kind of a direct pressure or irritate of the nerve, and that will be followed by post-operative, weakness of the patient. Did you face that, Dr. Khattab, when you use everything, it's available for you to control that, please? And thank you so much, you guys, for your presentation.
Thank you very much, Dr. Khalid, for your nice comments. It is really nice. Regarding the anterior tear or tear that is really irreparable, maybe very close to the nerve root, I think the use of fibrin glue or something like Tachosil is good in such situations. In anterior tear, it is completely difficult. So you only simply cover your field after finishing the surgery by Tachosil and the fibrin glue, because it is irreparable. And as well, if it is related to the nerve. And at the end, before closure, before tight closure, I recommend that you can ask the anesthesiologist to do something like Valsalva maneuver to see and assess the integrity of the situation down there. Plus, I do agree with our colleagues, as I told during the presentation, myself, in such a scenario, I put a drain in order to decrease the pressure over my closures, and I remove it after 3 or 4 days. And keep in mind that prophylactic antibiotics is mandatory. Prophylactic antibiotics is mandatory. Regarding the second question, when I use everything, Tachosil, fibrin glue, fat graft, and even muscle flap and watertight closure, alhamdulillah, that I didn't have any pressure over the root or any neurological symptoms that is followed. Although I'd like to highlight something, because it is also a question that delivered by some of the attendees, when to intervene. To intervene when the patient has clear symptoms like positional headache intolerable, refractory to medical treatment, and refractory to the subarachnoid drain, and refractory to Sidamex, and no way. So he has symptoms. If the patient starts to develop photophobia, if he has projectile vomiting and nausea, because all of these are alarming signs, he may develop conization or even stem conization. So it is mandatory at this time to intervene. These also questions written by some of the attendees. So I want to highlight all of them at the same time and comment about that. Do you agree, my friends, about that?
Yeah, I agree with you when it comes to anterior dural tears in the lumbar region. Yes, I wouldn't. Well, basically, you can't repair them, right? You'll probably try to use sealant as much as you can just to cover around it, but most of the time you're not able to get to it. I would say observe your patient. If for any reason he continues to be symptomatic and draining much, don't hesitate to use a subarachnoid drain, right?
Yes.
You need to divert the CSF pressure from your side of the durotomy, above the side of the durotomy, to decrease the pressure and to allow that dura to heal. Now, in a lot of institutions, subarachnoid drain is applied by interventional radiology, right? If you don't have that in your institution, get familiarized at least once with the subarachnoid drain. I used it once in my career, and basically, it was the first time to use it. We had the nurse in the OR basically holding the pamphlet of the subarachnoid drain and showing us how to use it step by step, which was pretty crazy, right? We should familiarize ourselves by using it at least once or reading how to use it. You're not gonna find a neurosurgeon all the time in the OR to help you with putting that in. It's pretty easy, actually. It's like putting a central line. The steps are not that difficult, but I would encourage everyone to get familiarized on how to use a subarachnoid drain, in case you don't have someone in your institution who can apply that.
There is a comment or question from one of our active young colleagues here, one of the most active orthopedic surgeons, Dr. Muhammad Hani Ashur, asking about continuous aspiration. Every week, the patient present to you with the swelling posteriorly in his back, and he start to aspirate on weekly basis. Do you recommend that?
I don't.
Actually, no, I don't.
Omar?
No, actually, I will not.
Why?
Not do it. Actually, I will observe him. I had one orthopedic surgeon, which he had a swelling also, pseudomeningeal, and I gave him both the option. And he's an orthopedic surgeon. He knows what we are doing. And I told him that we can take you for the OR and release it and suture it again. But we agreed that we'll observe, and that's it. So we didn't do it at aspiration, although it was very tempting to do the aspiration, but actually it's risky. Maybe it will cause meningitis, you never know. So I will not use it actually. Maybe it is.
Stop introducing needles in your wounds, right? That's not great. You don't want to.
So are afraid about risk of infection, developing meningitis. Maybe you can decrease the CSF pressure rapidly. That may cause drop in the position of the core. Maybe. Okay, there is one of our colleagues, Dr. Basim Shaman. Kindly unmute yourself and deliver your comments. Dr. Shaman, Dr. Basim. Dr. Basim.
We cannot hear you, Dr. Basim.
Right, let's move to one question till we figure out what's wrong.
Can you hear me now?
Yes,
okay.
We can hear you. We can.
Thank you very much for your comprehensive discussion for this important subject. Actually, I just want to share one experience with everybody. I has a patient. He is in his 50s and he is a heavy smoker, has severe spinal stenosis. We did decompression for him. Intraoperatively, we discovered that there's an incidental durotomy, and the first we decided not to repair the dural tear and just to put sealant. We put the seal and a good hemostasis with a tight closure. Bed rest for 48 hours. Unfortunately, the patient continued leaking until 1 week. We took the patient next day to the theater. The next week to the theater, we did a closure for the durotomy and put Duragen, and we did a tight closure and inserted a drain. The drain is continue presenting CSF fluid for 1 more week, and but we get a good healing of the wound actually. The thing that I want to share with you, once we start using acetazolamide, next day or 48 hours after acetazolamide, there was a significant drop in the CSF amount come out of the drain. It was 50 to 60 ml per day. After acetazolamide, it was dropped to 10 ml per day. And the thing that I want to share with you as well, the patient had a headache after the surgery, and he was complaining from significant headache, which was not controlled by any other pain medicine. I did some online search and I found the sumatriptan. Sumatriptan is the one of the medicine that is used for treatment of migraine. And there are oral and there are subcutaneous injection of sumatriptan. And there is a case study encouraging using sumatriptan because the mechanism of action, it works as a vasoconstrictor. So as like migraine, it causes a vasoconstriction in the brain vasculature. So you can give 6 milligram subcutaneous BID. Immediately the patient next day, his headache very significantly get improved. So don't leave the patient to lose too much CSF. Use acetazolamide for maybe 48 hours, as you said. And sumatriptan is very effective in controlling headache associated with CSF leak. And thank you very much for your presentation.
Just a clarifying question, Dr. Bassem.
Yes.
Where's the drain? You put it the drain?
The drain was put in the epidural space through the fascia, away from the facial incision, tight closure of the fascia and subcutaneous and the skin, and the drain was just and the separate incision away from the surgery incision.
Okay, thank you, Dr. Bassem.
Thank you very much.
Your experience. Actually, the dural tear is a very controversial topic, as we mentioned earlier. Sometimes you have to take the patient, unfortunately, again to the OR and to use the old tools that you have it in your toolbox. And what's your comment, Sameh?
Yeah, I have a very important point about sumatriptan. I think Dr. Saeed as well from Qatar also mentioned about sumatriptan as a way to deal with your CSF leak. So it's was mentioned by a couple of the audience as well. So we have around 20 questions, guys, and we have less than 15 minutes. So we need to go really quick through the largest number of questions that we have over here. One of the attendees.
Can I say something? Hello.
Hello.
Yes. Dr.
Saeed, yes.
Yes. Thank you very much. Dr. Bassem and I did the case together, and I've been using sumatriptan for last probably 10 years, and it is fantastic for headache. And this case, this was the first time I used acetazolamide, and it reduces the amount of drain significantly. And also, other thing is tunneling of the drain is very important. If you leave a drain, tunnel it so that you can remove it sequentially. And it allows the tract to close behind it. Otherwise, sometimes there is a risk of developing CSF
fistula.
Sinus fistula, yes.
Okay.
But we managed to this patient with just one surgery and acetazolamide and sumatriptan.
Wonderful, thank you.
Thank you, Dr. Saeed.
All right, there is a question here regarding management of dural tears when it comes to ACDFs. So basically anterior cervical dural tears. What do you guys do with those?
For cervical anterior tears, actually, I have no problem at all because, you know, most of the patients are either post-operatively standing or lying flat, supine. So there is no stresses on the anterior dura. This is number one. Number two, actually, the blood which is present anteriorly after ACDF is actually clotted and becomes something like a sealant, like the blood patch, which some colleagues may use in dural tears. So it heals very rapidly and very well. Plus, if you have some fibrin glue or if you have small tachocele, you can apply it over the tear. So I think it is, you know, not that very serious scenario if you face it during your ACDF.
Omar?
Yeah, I agree. Totally agree with you. Actually, it's not that common too, except in the cases like OPLL and where there is the ossification ligamentum flavum also. Sometimes it will cause tear or the dura. But most of the time, actually, as Dr. Khattab said, by standing the patient, the pressure is low at that level and it will heal by itself.
Yeah, cervical dural tears are much easier to manage than lumbar dural tears. Unlike most of the surgeons, believe. Just getting your patient standing, getting that hydrostatic pressure to decrease by putting the patient in reverse Trendelenburg or standing or walking, that helps you a lot. Your dura will heal eventually. It's really challenging with anterior lumbar dural tears more than the anterior cervical dural tears. I have another question here. When to interfere with pseudomeningocele?
You know, I had a case. It was OIL, ossification of the yellow ligament, and I planning to do in-block laminectomy for the patient. It was dorsal, I think from dorsal 3 or 4 down to D12. So it is a very huge distance. And while removing the lamina and block, we have all this distance dural loss. And the patient, what shall we do? There is no way to control all this huge distance. So we tightly close the wound and allow the patient to go. Of course, he improved regarding the compression. And after a while, he started to develop pseudomeningocele. After 3 months, there will be a pseudocapsule will be formed around this huge or the massive tears. And after 3 months, you can go simply and go through this pseudocapsule and do double breasting of this pseudocapsule. It will act as the new dura for your tear, and you will have excellent results. I think we have 2 cases like this in our center.
Right. Another question by Dr. Osama Ataya. When do you discharge the patient in different situations? Omar.
Discharging the patient after the dural tear, you mean?
I think after the repair, after you repair the dural tear, when do you discharge your patient?
So if the patient is asymptomatic and the wound is dry, actually I'm discharging the patient directly after the procedure. So if it is like after 1 day, I will ambulate the patient. So I will keep my patient for 24 hours bed rest, then I will start ambulation. If he started the ambulation, I will discharge him then the 2nd day after the procedure. And then I will bring him early in the clinic if I'm worried about the repair. So each case is actually, if the repair, you are not happy with your repair, or if the defect is large, maybe I will keep him for another 2 to 3 days. But if it is small tear and the patient is asymptomatic, I will discharge him the 2nd day.
Yeah, I would probably do the same. That's one of the things that I hate about drains regarding keeping the drains for 4 or 5 days. In North America, guys, a hostel bed per night costs around $5,000. All right, so basically, and the healthcare system is covered by Medicare or Medicaid over there, and no healthcare system in the world would pay $5,000 for a patient to stay in the hostel for 5 days just to deal with dural tear, for a surgery that already has a CPT code with an exact amount of number for reimbursement. So whatever you can do to get your patient out of the hostel as early as possible safely would be great. The other thing is, one of the things that we know from the literature very well is that hostel stay is associated with a higher incidence of wound infection. So if there is a way to manage dural tears and to get your patient out of the hostel as early as possible, that's the way. I personally discharge my patient the 2nd day post-op. I keep him flat overnight, ambulate him in the morning. If he's fine, I'll discharge him immediately. If he comes later on with a dural tear, I will deal with it, but I will not keep him in the hospital just for observation if he comes with a CSF drainage from his back. Another question, experience with blood patch, Omar Khattab.
You know, regarding the blood patch, there is 2 ways to use. One way is that you can collect some blood and inject it at the site of the drain if it is the source of drainage, okay? But I think our colleagues is speaking about injecting intrathecal blood. Injecting intrathecal blood to settle down and collect the platelets and the fibrin to seal the tear from inside. I don't have experience about that, but it is stated in the literature and it have positive effects.
All right, there is another question by Dr. Khalid Faraj as well. Is there any tricks or excellent way to treat extensive CSF leak from, so basically the same question about anterior cervical leaks, but here he's talking if you get an extensive frontal meningocele.
It will be a case record, Dr. Khalid.
Yeah,
And,
it's just,
anterior meningocele.
I never saw it.
I think it will be a case record because there is no actually a capacious space to have to. In ACDF, it is simply small disc, and you put the cage, and there is no space to develop this meningocele anteriorly. But I think it is stated in some literature, or I thought in one of the webinars which is running nowadays, that there was a pseudo meningocele or something like anterior herniation of the dura in the ACDF. I think, and they managed it by getting the patient back to the operating theater. I don't know. I don't know, Dr. Khalid.
yeah, just pray a lot, Dr. Khalid, in Ramadan that you don't see one of those. Okay, atropine and neostigmine given together is effective for refractory headache due to CSF leak. Any experience with those, atropine and neostigmine?
Me, no.
No.
Yeah, me neither, but a good point. What's the sign that told me that I'm done with repair to the dural tear intraoperatively? I personally do Valsalva to 40, all right? And then if I don't see any CSF leak, make sure that when you do the Valsalva, your field is really clear, right? Because you can see some bleeding coming here and there, and if you think that that's CSF, make sure first that you assure hemostasis around your dura, all right? And then do the Valsalva. If you don't do any CSF leak, then you're probably, well, hopefully, as Omar mentioned today, since you have a 9% failure rate, then you're probably safe. Dr. Khalid Faraj has another comment, and we have 5 minutes. Go ahead, Dr. Khalid.
For the frontal large pseudomeningocele, I sent actually some photo to Sameh. I don't know how, because he's a new generation. He can show it to you guys, but just to see as a experience in in your practice there. So Sameh, you know that case very well. There is it's a huge extensive pseudomeningocele. It is from the ACDF, extended from the chin to the chest wall, and it is a huge one. So just in case, may anyone he will face it in or we face it in our practice there. So how to deal and manage this condition, So I don't know, Sameh, if you want to share, the audience about that, photo, the picture I sent it to you. It will be appreciated.
I prefer not to, Dr. Khalid, because I don't want to show any surgeons complication. We're here all for learning experience.
No,
but
this is actually for learning experience, Sameh. It is not. We are not mentioning the surgeon or anything. We need just in case if we face that scenario in your practice, what we should do, which is really good. As Dr. Muhammad Khattab, he said that it will be as a reported case, yes, but unfortunately it was not reported there. So we need just to learn. You said that we need to learn, yes. The simple things that we can manage, but for this one here, we need to know what we should do.
All right, thank you.
So I think no more questions, dear friends, and no more comments. So it is time to conclude. So I think that it is important to be very cautious while you are managing your patient, and it is always, the less is better. I mean, prophylaxis, avoid complication. How you can suspect you may face dural tear if you have long-standing spinal canal stenosis in degenerative cases, for example. So very meticulous dissection of the ligamentum flavum from the dura is mandatory. In cases, some inflammatory cases like OIL, ossification of the yellow ligament, you have a lot of adhesions and adherence of the yellow ligament after ossification to the dura. So very cautious and very meticulous while removing the lamina. And also in some trauma cases, when you have a split fracture in the lamina posteriorly and you decided to decompress, for example, you may suspect a dural tear. So in such scenarios, meticulous dissection, be careful. At this time, if you face dural tear, ask the anesthesiologist to decrease the respiratory rate and to decrease the tidal volume, to decrease the pressure, and by this mean you can able to deal with the dura. Sometimes you have the rootlets coming out from the dural sac. How to manage them? By putting this patty or this times the colleagues put Surgicel to put the rootlets inside and suture the dura. You need to be ready with any armamentarium. And nowadays there are some staples. You can use this metal staples and suture the dura with this metal staples, with the staples instead of doing the sutures. Also, it is important to know that the MRI, Sameh said, the radionucleotide cysternography and the CT myelography is the ways to diagnose a dural tear that is lately presented. Regarding the laboratory, beta-2 transferrin is mandatory. It is a protein unique for the CSF and the inner ear perilymph. So beta-2 transferrin is mandatory. And as we heard all through this presentation about the evidence-based, what is written in the literature, what is with, what is against, really I enjoyed this fruitful presentation, gentlemen. Amazing presentation, Sameh, as usual. Nice to hear from you, Omar.
Yeah,
thank you.
Thank you,
very
Dr. Khattab.
You have announcement, Sameh, regarding the AO Spine Fellowship. I think you need to announce something about that.
Before we go, I just want to remind you guys of our next webinar that's going to be next month. It's going to be on June 20. It's basically titled My Worst Case. This is a very interesting webinar. We're going to have speakers experienced speakers from all over the planet, actually. They will be talking about the ugly side of the story. They will be showing you some of their worst cases and how they manage them at the end. So I would advise you all to join us and enjoy the wonderful talks. Last but not least, I would like to remind you of the deadline for the application for AO Spine Fellowships is approaching. It's May 31st. So renew your membership. If you're not a member, join AO Spine. If you're a member and your membership is expired, renew your membership and go through the guidelines of the AO Spine Fellowship. You may be one of those lucky ones who can join one of the prestigious centers around the world. Before I close, I'd like to thank my co-moderators tonight. Dr. Mohammed Khattab, thank you for being with us. Always a pleasure having you on board. Omar, thank you for taking the time. Thank you for the presentation. And we'll stay safe, guys, and Eid Mubarak, and hope to see you all soon.
Inshallah. Thank you very much. Thank you. Great effort. God bless. Stay safe.